So I'm really excited for our State of the State Behavior Support. And I don't know if it was Heidi, we talked about what the theme was, and they come up with here's the buzz. So put the B on the slides. So we're excited. So we have 3 representatives from DODD. We had a couple folks that had some other things going on. They couldn't make it. So Katie is helping fill in for that. So we have Heidi, Heather, and Katie. It's all yours.
Thank you. We were just going to do some brief introductions first. There are so many faces in the room that I know, which just says, you've worked in the field for a very long time, right? So I'm Heidi Davidson. I remember when there was only one Heidi at the department, but now there are, I think, 4. So, right, that's how long I've worked here. I have worked in the field for 34 years, in Ohio for 24, right? The department for 20. I have worked in different capacities at the department with behavior supports for more than 15 off and on. Currently, I am a part of the Ohio ISP team. I'm a regional coordination manager, and that tells you nothing, right? But I have three regions of the state. So I have the east side of the state. My partner, Lisa Allersmeyer, has the west side of the state. So I have regions 4, 5, and 6. And we try to coordinate services and make sure that all the different units at the department know what's going on with everybody else. We have some routine meetings, and we do that, as well as promoting and working with the Ohio ISP, which includes all planning, including behavior supports. And thinking about that, I work very closely with Heather, who can introduce herself.
Good morning. All right, now I can see your faces. This is awesome. I am Heather Leffler. I am a cross-system regional liaison with DODD. I do a lot of work with multi-system youth. I work in most of Region 5, and I have a few counties in Region 6. So if you just look at 4 rows, those are my counties. I help 14 counties try to find services for youth who are in crisis. And I have to say my counties do a great job, and we worked really hard at that. I've been at DODD for a really long time. In my 33rd year, how'd that happen? Started out as a DSP doing respite and family homes. So, and I've done just about everything. Did regulatory for DODD for about 16 years, lots of accreditation reviews, and then switched over to policy, helping people coordinate services for mental health needs. And with that, I'm going to turn it over to Katie.
Hi, everybody. My name's Katie Willie, and I'm representing the Office of Compliance today, our new name. So I got that right. That's good. So my role at this point is an accreditation manager. And as you all probably heard, Lisa Burt was promoted. So I'm taking over regions 4, 5, and 6 primarily for accreditation. And Tina Haggerty, my counterpart, is primarily in regions 1, 2, and 3. So I see a lot of familiar faces out here, which is good. And there's a lot of people I haven't met. So I hope that I get to meet you today and find out who you are and where you work. So with that, I think I'm going to switch to the other mic. Okay, we'll see if this one's working. It is. All right. So before I start, I'm actually not going to move the next slide yet, because our first slide is going to be what are the top 4 behavior citations. And so I want you to think about that for a minute. And when I saw the data, what I'll say is I was surprised by the results. And so I want to put some context with that. Remember that these are any citations issued to county boards for accreditation or for provider compliance reviews. So that might help you get to a better place than I did. So anyone have a guess for what's in the top 4 at all? No guesses. Okay. Well, if there's no guesses, I will go ahead and proceed. So these are our top 4 sites for behavior support, and they are also in order of the most frequently cited, which is what I also found. I was surprised by the results of that personally. So our first one is the assessment to planning. The second is the restrictive measures are implemented, but not in the plan or HRC approved. Third one, when we see those restrictive measures in the plan that weren't approved by HRC. And fourth, the 90-day reviews. So I'll say out of those four, I didn't have one on the list. And that isn't the order I would have thought they would be in. So I don't know, again, we're gonna dig into these in each slide. So once we go through that, then you might see why those actually with our data were the top ones. So our first one. This one I was surprised was on there, but when you think of it in the context of behavior support, one thing we have seen out and about, and this is our number one cited thing, is that people will get a lot of really good information and assessment and identify those needs, identify those risks, but it doesn't make it in the plan. And we don't identify what supports are needed or services and who's going to provide that support, be that paid or unpaid, to make sure that that person can be successful, because we want them to be successful. So I think it's one of those gaps too that recently, even more so, people know the people they're working with really well, and they know them, so you kind of miss that gap. You feel like you already covered it, and so you don't recognize that it wasn't in your plan, because that's something I think when I read even reports that I've written in the past, I go back and I'm like, wow, I wish I could kind of do a redo on that a little bit. So that's where that one kind of lands. And so you could see why that one would be a top site, because assessment and planning in general, that's a broad, big area, and behavior support fits there too. So moving on to our second one, provider implementing restrictive measures not included in the plan. So you might say, how could you cite that to a county board? Because typically that's a site you would see maybe for a provider compliance review as well. And that's our number 2 site to county boards. So how would that happen? So one thing is we go out and we talk to people when we're out on accreditation reviews, when we're out on provider compliance reviews. We're out there, we go to where people live, we go to where people work, and we're talking to them. And if they don't want to talk to us, sometimes their family might, sometimes someone else who lives in the home. And SSAs talk to us and family members. So I think what happens here is we'll see in case notes, or we'll see in 90-day reviews, or we'll go out to someone's house and maybe all the cabinets are locked in the kitchen, and we'll say, oh, like I didn't see that in the plan. And they say, well, mom always just did that and prefers that all Katie's food's locked up because she eats a lot of snacks and it always spoils her dinner, kind of thing. And it's an adult living in their own place. So again, some of these things are just seen when we're out. And then maybe through case notes or through interview, it's evident that the whole team was aware it was going on. And I think in most cases, they just didn't see it as restrictive, or maybe they say, well, mom said to do it, so we did it, and not recognizing that it's an adult and that you're in a rights restriction area. So the other thing we have down there is gaps in monitoring services. So one thing that we've seen, and it was really hard with COVID, it was hard for a lot of people. We didn't get out so much. We didn't get out. You know, you guys didn't get out. A lot of people weren't getting out anywhere. And so breaking out of COVID, people did that at a different pace. So some people got out a lot sooner than others. Some people who actually had the highest risks were out sooner because maybe for mental health reasons or whatever else, they needed to be back out in the world. So that unwinding period was different for different people, but we've gotten into situations where you might meet a team of SSAs who there was a case where they had been working with someone for 3 years, but had never met the person ever and had never been to their home. And so you're going to have gaps in what you know about that person, because there's the things I might tell you and present to you, and then you might go to my house and say, wow, she had a really good acting career going on over there. She presented herself a certain way, but now that I'm at Katie's house, I don't think that's reality at all. So I think that not having people out there and not being able to check in, there were a lot of emergencies. The SSAs were putting out fires every day. So quite frankly, they couldn't be out there as much as they needed to, because they had to deal with immediate needs and situations. But what that did create were some gaps in monitoring, that I feel like that's how we get that number 2 site where we landed in that zone. Okay, so we'll go on to the next one. For restrictive measures in the plan are not approved by the HRC. Big one. I think a lot of people just don't think of some things as restrictive that we consider restrictive. And I think that we can all fall into that trap. And so it's always thinking about, if this is something I wanted to do, could I do it, is kind of where I start, and then working your way back from that, because there can be influences in that. So again, I use the family one. I think that the Ohio shared living can be a tricky one. And that can be too, where maybe someone had paid supports that was not a family member working with them. And then you have a change where that family member becomes certified to be a provider. And the team just doesn't look at that plan as being different. So maybe the family member who lived with that person said, well, they're living in my house and this is what we do. And then when they become a provider, it doesn't click like, well, now you're a paid provider 24/7 because you're billing shared living every day. So now that is a restriction, whereas before you're just, sister, your mom, your cousin, whoever's living with you, who's your family member. Now we've stepped into a different realm. So just that is a great service. Who better to care for someone than a family member who knows them and cares about them? But just that's something to look out for, where we see that in plans more so than others at times. Another thing we see is SSAs are really trying to be responsive. So they hear about a change. So maybe all of a sudden I have my sister as my shared living provider. And so the SSA wants to get that service authorized. They want that provider to get paid. They want me to have who I want working with me. And they want to be diligent. They're trying to make those changes quickly in the plan to be responsive and make sure everything's working. And in doing so, sometimes don't maybe get through the whole team process. Maybe they don't talk to everybody on the team. And I think that that's where sometimes you can get that outside perspective of, oh, well, now if Carrie's going to be Katie's provider, then Carrie was like locking Katie's food up at all these certain times. So now we're going to have to talk about that in a different way. Whereas before it was family doing what family did, and I chose to live there. So just keep that in mind. But just did want to point out, I think there are a lot of people who are really just trying to do the right thing. And sometimes we don't land on the answer that is, maybe if the Office of Compliance comes out, we might say, you got really, really close, but actually in this situation, now we need to reevaluate it. It's people really trying to do the right thing. And sometimes they just need that outside looking in. So if you can do that for your teams, that could help them move forward with that too. And then rights restrictions. Rights restrictions are the biggest ones we see written into the plan without that approval. And it's just, again, it's hard because if you know someone too, and you've worked with them for a while, or maybe you're in a smaller community where everybody knows everybody, their risk, their needs. And so not saying that support isn't needed, but maybe now you need to put it through HRC. So we're not saying they don't need the support, but maybe we just need to make sure all those pieces are in place. Oh man, 90-day review. So I thought this would have been higher on the list. And so the reason it's not, I realized in the data, is probably because the provider reviews thrown in there, not just accreditation. So the big thing with 90-day reviews, so data. So you want it to be focused on data. And going back to a little bit of the keynote speaker this morning and thinking that you know something, maybe it's just the regions I've been in. I had a really clear idea when Heidi and Heather were getting the data pulled for what these top 4 sites were going to be. In my head, I knew what the top 4 were going to be, and I knew what order they were going to be in, and they were not. So we have our own experiences that we base that off of. So maybe it's the regions I was going to more recently, or maybe it's skewed. Maybe as a staff member working with Katie, maybe I'm always hitting Heidi. And so Heidi thinks that Katie has a lot of physical aggression issues, whereas anytime Heather works with me, I never do anything like that. So it's like, well, Katie's always pretty good. She doesn't have any issues. And Heidi thinks Katie has issues every day I see her. So again, it can just, your data, your vision can be skewed based on just what you know. So it is important to review those numbers with teams, because what someone's seeing at day program, what someone's seeing at work, what someone's seeing at home can be really different based on maybe how I want to present myself or how I react in different environments or with different people, and then trying to figure out why that is where. So the big thing I would say is, yeah, we want to see the effectiveness. We want to determine based on that data if we need to continue, discontinue, revise, and we need to document it somewhere. No prescribed way to do that. You can do it in case notes. You could do it on a form. I've seen a lot of different things in a lot of different places. I would really, really encourage you to have a process where you work for that to be the same, because sometimes you'll be in one county and everyone's doing it differently. And again, that's permitted. But I think what that makes it hard is for management staff to then make sure it's getting done, because if I do it one way, Heidi does it another, Heather does it another, you might miss helping someone to stay on track where you're like, did you do your 90-day? And if you don't know where to even look for that, that can, you might not be able to support your team as much as you want to be able to. And then we see too, sometimes in those 90-day reviews, not all the teams included. Now we know not everybody can come to every meeting, but can you get the input from them? Is there a way to reach out so that their input could be shared at that meeting if they're not able to be in attendance? Because having that perspective, again, if it's just Heidi, who I hit every day I work with her, we might impose additional strategies that if we had a bigger perspective, it might be, okay, what specific strategies in this environment are not working for her if that's the only person, or is that the only staff that it's against, or just trying to problem solve that more strategically. And so going back to the 4th point, no clear process, that just goes back to if you can have a consistent process, at least within your agency, I think that helps a lot just to keep everybody on track. So with that, I think we will get to now the really exciting part, hot topics. So I'm going to pass it over to Heidi.
I can use this microphone so you can keep that. I did want to say it was interesting that when Katie was talking about the data and how she said that in her mind, she knew what the sites were going to be. She thought she knew, right? But that she also kind of thought, well, maybe it was just because of where I was. It was also interesting to me. So we have a data team at the department. And so one of our data folks actually ran the sites, and she gave us some information of go with the top 4, because I'm immediately like, why 4? Why not 5? right? Like I'd imagine it should be 5, but these top 4, and then there was a significant cutoff in the amount of citations and the number of citations before we hit number 5. That's why we went with 4, which who knew, you know? Okay, let's hope that I hit the right button. There we go. Hot topics. Now our hot topics are not based on citations. It is based on the number of emails, phone calls, messages, everything that Heather and I receive, you know, personally and through the behavior.support website. So that is why there are 6 of them, because there are these 6 general areas where we tend to get a number of questions, right? Identifying rights restrictions aligns very well with some of the citations that Katie talked about, right? If you don't know it's a rights restriction, you're not going to put it in the plan, or if you do put it in the plan, it's not going to go to HRC. A number of things with that one, but that one is up there. Informed consent. That one we get a lot of questions about. Connecting to others. You know, so much of what we do personally, we do because of the relationships that we have, the connections that we have with people in our lives. And the same thing holds true for people who receive supports in our system. Supervision, that has kind of been a question, a newer question that's been coming up. You know, we're going to talk about each one of these individually, but that one is new within, I would say, the past year or so, and has kind of been a little bit of a surprise to me. Technology, when is it restrictive? When is it not? And then the last one, the big rule change, blunt suppression. So those are the hot topics that we're going to talk about. And we're going to start with identifying rights restrictions. Is there anybody in the room, I'm looking around, from Lorain County? Oh, that's so sad. Lorain County Board has developed a series of videos. Hey, I see you now. Thank you. Thank you, Heather. So Lorain County Board has developed a series of videos. I think there are 8 or 9 altogether. I can't remember. That some folks who live in Lorain County are the actors in their videos, and they are fabulous in the way that they describe what rights restrictions are. You know, they go through like everyday life and making decisions, and you know, when people are trying to get you to do things that you're not. But anyway, they have them on their website. They have allowed us to share them on the department's website. And you all know we have training on rights every single year for so many different people. It is a fabulous way to share information with people who may have looked at the list of the 24 rights for the past number of years. Like it's a new way to maybe share some information about the rights that a person has. So big plug there, love the videos. And I really do hope they make people understand. My go-to is always, could somebody do it to me? Would that be okay? And if not, it might be a rights restriction. We might need to talk about it just a little bit more, but it is definitely a hot topic. It is also, you know, rights restrictions, the number of them is up here, right? And then when we think about manual restraints, mechanical restraints, we're down here, much lower numbers. We didn't include any of the data. But then timeout is like, you know, barely sitting on the floor. I think there's less than 30, maybe even less than 20 people statewide. So rights restrictions are where we tend to go when people are having their worst days, which makes sense why it leads to a lot of questions and misunderstandings. Informed consent. Lots of questions about informed consent. So informed consent, you know, the explanation of a restriction to a person informs them. and then they consent, right? That simple, basic. But the idea that you have to explain it in a way that the person understands, you have to use language geared towards your audience, whether it's the person, whether it's a guardian, whoever is providing the informed consent, really explaining it to that person in a way that they can understand, and not forgetting to explain, oh, hey, you can say no, right? You always have the right to say no. Like some of the things that I see, like I think, oh, somebody told me they were going to do that to me, I would say, no, thank you. Let's try something else, right? Like most of us are never going to tell people, yeah, it's okay if you put your hands on me. Sure, right? Oh, it's okay if you take my phone at 10 p.m. That one would be a killer, right? Like we can barely leave our house and forget our phone. We might be 20 miles down the road and we're going to turn around and go get it. A lot of us. Anybody else would do that? Okay, I see some hands, no arms, but I saw some hands, right? So could you imagine if somebody said, yeah, 10 o'clock, you're gonna turn in your phone because you've done some inappropriate. I would say, no, thank you, right? The Ohio ISP has an informed consent page. Since the development of the Ohio ISP, we've had a number of questions about that page. Sometimes folks have thought that perhaps that page is the behavior support plan. It's not. It is simply the informed consent page. So where I talk to Heather about here's what we're going to do, we need to do, we've talked about the good, the bad, the positive, the negatives. We've gone through all of that. That is what I'm going to put on that page. What I discussed with her about the restriction that will be going into place for her. Like that's all that is. That one page is just the informed consent where you carry over that conversation. Okay. So those are two big ones. This next one is huge, right? Like, I know that you all have heard for years that so often behavior is communication, right? That's how a person shares their dislikes, their frustration, whatever it may be. Negative behaviors are often communication. And that happens because of an inability to make those connections, a lack of connections or a lack of understanding, and really allowing somebody to right? We shouldn't be allowing, but we do. People tell you all the time, oh, I can't do that because they won't let me. Whoever the magical they are, they won't let me. So allowing a person to live their life as a full adult with equal rights that you or I have. And that happens as we connect with people, as we develop relationships. We help advocate for people to make their own choices and not for us to make them for them, right? And that's hard. That is so hard without relationships. The two sub-bullets on here, honoring the person's choices, gosh, intimate relationships. That's one that nobody likes to talk about, right? Because if you have a disability, you shouldn't want to have an intimate relationship. Everybody wants to have intimate relationships, and we all define that differently. But so often the people in our system aren't permitted or allowed to do that often leads down a bad road. Bad for the person, bad for the people supporting them, and bad for the person that they were trying to make a connection with, who now people have put roadblocks in place so that can't happen. Huge, right? Friends and family, who you can hang out with, how often you can see people. Those connections are something that everybody needs in their lives. It helps keep you happier, even if you're kind of a loner person, there's still someone somewhere that you want to make a connection with that you haven't been able to. And often it's because your team, the people who are there to support you, are kind of standing in the way. I don't know if you all are aware of this, and this is a huge plug. May 23rd, we are having an innovation summit in person, and it is all about relationships. There are some folks in the room who will be presenting there. One of the sessions is actually on intimate relationships. And I will have to say that there is a gentleman, there are actually two gentlemen presenting in that session, along with some SSAs from Tusk County. And I have been having conversations with these gentlemen over the past week, and they have touched my heart like hasn't happened in a long time, right? Like a long time. So I can't wait for it. So if you can make it, sign-ups are still open till the 16th. Love to see you there. It'll be in Dublin. And we are diving deep, deep, deep into relationships all across the board. There's a number of sessions, but one of them is on intimate relationships, another one on connections. It'll be a great time. Yeah.
Heidi, I got to weigh in. So what do you do when your team is stuck, right? You've got some team members who are like, no, this person is not appropriate. No, this is not okay. What do you do? Because the person is an adult, right? And I'll even say, you know, older teenagers, like they're getting ready to transition. We've got to start building those skill sets. And you've got accreditation in 6 months, and you're seeing this. And whew, what do? Well, first of all, you're going to meet that team member, family member, you know, maybe it's somebody in the community, maybe it's a different natural support. You're going to meet them where they are, right? You're going to build that relationship. This work is not going to tie nicely for when Katie and her crew come. You know, you're not going to be able to wrap it up in a bow. That's not how life works. But what you do need to do, and many of you are already doing this, have a plan. You know, we're working with mom. I know I've worked with many of you, and we're like, oh my gosh, we've got to turn this around. Well, you're not going to turn it around quickly, especially if you're doing it in a trauma-informed, respectful way to get that buy-in. It takes time. And it is so worth that investment, because you will be able to nudge, and we will be able to mitigate, you know, the risks that are associated with some relationships. And, you know, we'll be able to do that education, and we will get that buy-in. But again, it takes time. And I've even, you know, and Katie, I've asked her this question, you know, are you okay with that? And she says, yes, of course, as long as there's a plan. So just have that plan available, you know, be able to speak to where you're going. You're not there today. And that there's a good reason for that. You've got to meet people where they are. You cannot power over. That does not have good results. I think we've all seen what that can look like, and it's not pretty. It's not something we're proud of. So let's meet people where they are, build relationships, and try to move that. Oh, I lost the word, but just moving it along so that person can really exercise choice in their life. But you've got to do it in a way that makes sense for that situation. This is long haul work. It's sprinting and running marathons at the same time, because when you have that opportunity, you need to be able to sprint. All right. Sorry, Heidi. I had to add that.
No, you're good. Actually, I think we can move on to the next slide.
It's my turn.
And you can take over. Yeah.
All right. All right. Supervision. I was a little surprised too, like Heidi said, about supervision, but we are serving some people with very complex needs. And, you know, likelihood of legal sanction, we take that very seriously. You guys do a great job with that. But sometimes people push back on us when there's a likelihood of legal sanction, and we want to staff it in a way to ensure health and safety. And the person is like, no, get out of here. I don't want all these people around me, especially if they don't have a guardian, right? You know, we have to honor that. What does that look like? It can be very challenging. Heidi and I work with lots of teams across the state when this happens, and we will do everything to support you, because it's not easy at all. However, we've got to find solutions. And we do find them. Sometimes it takes a little time, but we will figure that out. If the guardian agrees to it, all right, we've got our informed consent. I still think we need to do a lot of work though with that person, because they're at the end result of this and they don't like it. So we're probably not going to have a smooth sailing experience supporting them, right? So we got to figure that in, and we've got to just keep working on that. Maybe the person agrees to it. And then they decide when Katie's crew comes out, and no, I don't want to do this. I've been thinking about it and I don't want to do it. It's a new person. Sometimes that happens. And that's okay, right? The rule says you can say no at any time, and we have to be ready to be able to support that person differently with alternatives.
Yeah, can I jump in for
of course you can.
minute? So this one was very interesting to me because for years, I have been telling people, no, supervision is not restrictive. 99% of the time, it's not restrictive, right? There's no blanket answers, but 99% of the time, it is not restrictive. And then I've got people calling me saying, hey, right, there was a citation, didn't make the top 4, which is why Katie did not talk about it. But what they have been seeing is, and it doesn't matter, there's a one-on-1, one-on-4, doesn't matter. But they have been going out and chatting with people. And what they've been hearing is, yeah, I hate that she's always right next to me. Hate it, don't like it, wish she wasn't, right? That is when it becomes a rights restriction, because Heather, who we never thought cared that she had a one-on-one
I care
staff, right? She then told somebody that, yeah, I hate it. I wish they would go away, but because of some things that Heather's been doing, can't go away. So that's when it becomes a restriction.
Thank you, Heidi. All right, we're going to move on to the next topic, technology. So we are constantly finding new ways to support people with technology. I don't even try to keep up. I love technology, but we've got a team at DODD. I actually tell families, and when I'm doing technical assistance, just have them come in, because if I share what's going on, they're going to have even better things to share with you. So it's beautiful to see how people's lives can really open up for better experiences. However, sometimes technology, depending on how the person is responding to it, it can be restrictive. If I don't want those cameras in my room, even though my mom wants them in there, that could be really restrictive. Trying to think of some other examples. I think I'll just move on. With technology too, with sensory needs, we're seeing a lot of people using technology to help with that. Again, sensory needs, those are supports, right? We don't ever do sensory interventions where people don't want them. You stop. And if you need a sensory 101, please, I'm your girl. I love that stuff, and I'd be happy to help you with it. I'm not an OT, I'm not an expert, but I live it every day, and I'm very passionate about it. But sensory, that's a support. That's not a restriction. Heidi and I, we get in these conversations with people where, they're afraid it's a restriction. And I'm like, whoa, how's the person responding? What are we using this for? And it truly is a support. But just a few little details can make it restrictive. And a lot of it goes back to how is the person responding to this? No blanket answers. The work is great, but it is so highly individualized. And that's where we need to be in order to support people to live their best life. Balancing that, balancing technology. It can get really challenging with teams and sometimes people who aren't necessarily in favor of technology. I see that a lot with maybe some of the families with some of the teenagers. Teenagers, aren't they fun? They're so much fun. But just finding those balances with your teams. All right, blunt suppression. I have lots of funny jokes about blunt suppression. My family does not think they're funny, but we've been immersed in blunt suppression. So what is blunt suppression? It's when a person is no longer able to function in their daily life. They're not able to walk. They're not able to feed themselves. Maybe they used to be chatty like me, and now they don't even care if anybody's even around them, don't even talk to them. That's blunt suppression. There's a loss of skill there after a medication is administered. We're looking at signs and symptoms. We're paying attention. This isn't anything new. We do this all the time. You know, when people are taking medications, we're making sure that, you know, the medication, they're responding well, and we're reporting that back to the physician. So we're just paying attention to people. Standard of care. This comes up for pre-meds and things of that nature. Dr. Sorg, I love our medical director. She did a webinar in December. Check it out in My Learning if you want more information. But she talked a lot about standard of care and practices for everybody, you know, in the general public. And if, you know, if teams aren't sure, you know, if they're at the dentist, we use this example a lot just because it really gets under my skin. If somebody's using a papoose board, you know, I don't get offered a papoose board when I go to the dentist. And it's, you know, is this something that's offered? Is this standard of care? And we're able to ask that question to physicians. You should feel confident in that. You're advocating for the person. You're just trying to make sure that, you know, the person is getting what they need. Do you have anything you want to add? Okay. We work together so closely, we can tell by just body language sometimes. So what if you are seeing where a person, you know, they started a medication and they are very different. They are not able to feed themselves. They are not able to get up and walk to the restroom. Well, anybody on the team can see that, and they just have to report that to the SSA. We've had several situations of this happening, and it's gone pretty smoothly. You know, everybody was really worried what that would look like. So you report it to the SSA, and then the SSA takes it back, or whoever's appropriate on the team. SSAs are not always the person who has the relationship with the medical providers. Usually that's the provider. So they're able to communicate that too. But the SSA has to know about it, of course. That's good. Service planning and monitoring. And then you take it back to the physician or prescriber, and you know they have a couple of options, of course. I mean, we're not questioning them. We're just reporting what we're seeing. And you know, we really want this person to be able to get back to their regular functioning. You know, they may change it. They may say, yes, this medication takes a little bit for the person to adjust. Within the rule, we allowed for 30 days before you would start the reconsideration process, because a lot of times psychotropic medications take a while before the body will adjust. Blood pressure medications, you know, the first couple of days, you know, it's pretty common that you're dizzy or you can't hardly, you know, like, woo, but then it subsides. So if the physician says, just hold on a minute, you know, I think they'll be okay, but get back to me. That is perfectly fine too. Or maybe the physician will go ahead and change the medication. And maybe the physician says, no, I'm not doing anything. And that's okay too. It's gonna be a chemical restraint, and you'll need to process it. You know, depending on the relationship, this rule is not intending us to get in between that relationship with the prescriber and the person. However, we are in a role where we're supporting people and we need to advocate for their best care. So just finding that balance. I think that's it on blunt suppression. All right. Again, no blanket answers. We have had this slide in our PowerPoints since 2015. I'm not kidding you. And it will stay in here as long as I am at DODD, and I bet Heidi too, because this is real. And that's what it is when you're doing person-centered work that's trauma responsive. Other states are really shocked that we do this. It's really fun to brag about all the work you guys do. So no blanket answers. All right. Questions and open discussion.
Answer. Anybody have questions? Come on, make them work. Let's go. Nothing.
Not a single question.
You guys must have done amazing. I had to leave for like 30 minutes.
I don't believe
yeah, I don't either. Yeah. Oh, here we go.
Hi. We have an individual who is she had a court order. It's a criminal case for no contact order for family members. Okay. And she is completely heartbroken by that. We talked to our Human Rights Committee, and they stated that because it was a criminal proceeding, that it was not a rights restriction. I just wanted to confirm that is for sure the case. And then is there anything else we need to do to help document that, although we're trying to follow the judge's court order, that we're also trying to help her through the process?
Okay.
Okay,
So,
that's a good one. There you go. Just when you thought you were going to get out of here, Heidi.
right. So court orders are always interesting, right? Depending on what county you're from, they're even more interesting in some places than they are in others. Sometimes probate court is more involved, sometimes they're not, right? But you said criminal court, which makes it a lot cleaner for me, makes it a lot cleaner. So she's not supposed to see family members, right? So that is part of the court order. So you determine if it's a restriction when you get to the point of, does the specialized provider of service have to implement restrictions to make that happen? So are they monitoring phone calls? Or if somebody comes knocking at the door, are they saying, no, you're not allowed to be here? If they have to do those things, then yes, you make sure all the details are in the plan, send it through HRC and go forward. It's really about, does the provider have to actually implement something that is restrictive? And in that case, it sounds like they might, but without knowing the details. Okay, so she's not just like, oh, they said I can't see my family, so oh well, right? Like, I'm not gonna try. Chances are she's still trying, she's still interested. So yes.
So are you saying if it's a court order, then it still needs to go through the HRC review process?
It's not necessarily the court order, it's those additional restrictive measures that the provider has to do, right? So in order to meet the court order. So the court order says no contact with your family.
To the department? Is that something that can be appealed to the department or ask a waiver on?
I can't hear you, Willie.
I said, is that something that can be appealed or request a waiver on that specific piece? Just because I think anytime we start looking at court orders and then we're going to throw it into our process and make teams jump through all the hoops with the HRC, I think we've stepped outside of our bounds. So
right, our bounds is the guidance to the specialized provider of service.
Because we don't have a choice. The court ordered it, right? The
exactly.
provider could be out of compliance with
the court order is between the court and the person, right? So if there's a provider involved that has to take additional measures, I think that's something you would share with HRC, right? That it is a criminal court order. And we've never, I'll just say this, in all the years that I've been doing anything with behavior support, so 2007-ish, we have never come across a situation that's never been brought to me where HRC said no and the court said yes, like never. 16 years and never. So I do feel like everybody understands it and everybody is making the right decisions. HRCs understand it, right? Your HRC needs to know when something is a court order and restrictions are built on top of it, how that might be a little bit different. And one would think if it was a criminal court and these were in place instead of this person being incarcerated, right, or arrested, which are two of the things that can happen as a likelihood of legal sanction. So you've already got that. There should be no reason why they would say no. So, yeah. That's
not my concern. It's just
what happens
overloading our system. It's just one more thing that we're adding to that. And
so it is a restriction. HRC says, and then the continued reporting every 90 days and the fade plan and all that. I mean, you still have to work through it because it's a restriction.
Right. Right.
And I think that's where it gets sticky. I mean, is that? Yeah, they didn't even want to look at it because it was court order. Yeah.
Need to mic.
I want to add too, aside from behavior supports, I hope you're able to find some mental health counseling to help this person get through this situation of not being connected to her family for whatever reason, but that's important to her, and we have to honor that. So I just had to say that because I don't want to lose forest for the trees.
So it sounds like you need to go back to your HRC committee and talk, and if you need support, you should contact these guys. But I still like what Willie said is that, okay, yes, it's a restriction. Is there the ability to have a waiver since it's court ordered in some of the ongoing monitoring, team meetings, all the stuff that you have to go? And I don't know. I mean, do you know if there's an ability to go to the department once we have said, yes, it's a restriction? Could we look at some different processes since it's a criminal court order?
I think you can always bring that information. What, that's above our, we don't weigh in, but you can always ask for that. Whether or not you get it, that's a different story. Yes, Katie.
I just, wanted to bring up very loudly is that, again, it's county to county independent. So I had a really interesting situation in one county last year where it was a court order and that kind of situation. And the person who actually ended up providing the support that would have been considered restrictive was the parole officer, was actually coming to this person's house and monitoring some of the technology things that would have been considered restrictive. And so none of the paid supports were actually involved with that. And so again, each county is so different with that and who's implementing it, and depending on the judge and even the parole officer as it may be. So it really isn't always involve any support staff in our system.
Sounds like a great solution. Parole officers do the restrictions, yeah.
And I just want to plug, we have an offender training, how to support people with offending behaviors at the end of the year, fall. And it's going to be a part 1 and a part 2. Part 2 is where we're bringing in parole officers, we're bringing in a defense attorney, and we're going to have all these conversations. So there's going to be additional training. I don't have a save the date yet, but I want to put that plug in just so that you guys will know. And the first training will be in person, second one will be virtual, and we will be recording. Sorry, Lisa.
Let's take out the criminal aspect. In Rule 66, it allows a guardian to prohibit certain people from being involved with a ward. And our probate court is honoring that. So if there is a justified reason, the guardian can submit something to the court, not criminal in nature, and make a restriction in place for access to that person. So what I'm hearing you say is that would need to go through our HRC if we're asking the provider to implement that restriction.
Yes. So right. That one was easy for me. Yes. So here's the thing with Superintendent's Rule 66. As a guardian, probate court, gosh, and I hate to even talk about this, but I will. Probate court has authority over the relationship between the guardian and the person. They do not have authority over the specialized provider of service. Our rules have authority over providers, and the rule requires that there's risk of harm or likelihood of legal sanction for any restriction. So if probate court says that Heather can't see her father, mom's guardian says mom doesn't like dad, and probate court says Heather can't see her father, there has to be, in order for the provider to implement that restriction, because it is a restriction, it has to meet likelihood of legal sanction or risk of harm, go through HRC, all of that. Now, if mom wants to come over and she manages that, that's up to her, right? And
so
it's,
what I'm hearing you say is that Even though the probate judge as superior guardian would say, I honor this request and there can't be contact, that the provider doesn't have to honor that court order. But the parent, that's what it sounds like you're saying.
Yeah, what I'm saying is we need to work the team process, really, right? Like guardian wants an outcome. Providers can only function under their requirements, which is risk of harm or likelihood of legal sanction, right? There may well be a risk of harm or a likelihood of legal sanction between what's going on between Dad and Heather. Yes, it is that ugly. And there are some counties where those kind of situations come up and they're very ugly. It's
so again, it will, I mean, that what you would suggest is that it does need, if there's active support from the providers to keep that court order going, then you do take it through HRC. HRC, if you show risk of harm, legal sanction, they should approve it as a rights restriction.
Yes. Yes.
And what if they don't? That's a good question.
Because the case we have in Jersey County wouldn't meet the criteria for what an HRC needs to approve something, but the court is willing to give the blessing, so to speak, that there can't be contact. But when you look at our rules, it does not meet our rules.
So it doesn't meet a risk of harm or legal sanction.
Right.
So then they decide
that's why I say, right, like, okay, so we recently updated the guardian training at the Ohio Supreme Court. So it was myself, Corey Ferguson, who's our family advocate, and Derek Graham, who's an attorney at APSI, and Kristen, who from APSI. And one of the things that we talk about in that training is the codependency that we all have on each other, which is why I say you have to work the team process, because the rules do not align exactly. They just don't. Yeah, and if you have a situation, reach out to us and we will
definitely
try to assist you with that.
It is 11.
We have another question.
Go ahead, one more question, and because it is 11:45.
Thank you. So two individuals, individual A, individual B, used to live together, boyfriend and girlfriend. Individual A sexually assaulted individual B, and individual A admitted to sexually assaulting individual B, and individual B she moved out of the home. The police were contacted, court, no contact order was in place. Individual A and B both went to the same day services, and what they did was individual A went Mondays and Wednesdays, individual B went Tuesdays and Thursdays. The court threw it out. So the no contact order was thrown out. Individual B still wants nothing to do with individual A and does not want to see him. However, individual A would like to see individual B and would like to attend DayHab every day so he could see individual B. Is that a rights restriction if we do not let him go back to DayHab on the days that she's there?
I'd say that yes, it is, but it seems like it's warranted, right? There's risk of harm to somebody else because we have that, and also likelihood of legal sanction. Yeah.
I just want to make sure. Thank you very much.
Thank you.
Thank you, everybody.